Hello everyone, welcome back to Radiology Short Cases. Today we have a 62-year-old male with history of right flank pain for past few days. Patient was advised CT of the abdomen. So this is an axial image which is taken at the level of the kidneys. So what we see here, there is heterogeneous enhancement of the right kidney with multiple ill-defined wedge-shaped hypodensities involving the right renal cortex. However, there is no perinephric fat stranding, fluid collection or hydronephrosis on this side, and also the left kidney is unremarkable. In addition, we can see there are significant atheromatous changes involving the abdominal aorta with both soft and calcified plaques. Let's move to the next image. So on this image, what we see, the right main renal artery is arising from the abdominal aorta. Its caliber is decreased. Also, it is not completely pacified. This is the coronal CT image of the same patient. So what we see here, main renal artery is arising from the aorta. There is a linear hypodense filling defect involving the proximal part. However, the wall of the artery is still enhancing, so it is not completely occluding the vessel. So based on these findings, right renal multiple infarcts with main renal artery thrombosis was the diagnosis. Now, what are the most common causes of the renal infarction? As in our case, there were significant atheromatous changes, so probably some embolus has dislodged within the renal artery. So most common causes thromboembolism followed by renal artery dissection, hypercoagulable state, any history of fibromuscular dysplasia or recent trauma, or heart disease like endocarditis, where also the emboli can move to the visceral arteries. What are the imaging findings which we see commonly? First, you need to remember that serum LDH is normally elevated in such cases because of the presence of cell necrosis in that area. And the modality of choice is CT angiography. So on imaging, particularly on the CT, we will see multiple wedge-shaped cortical hypodensities. And there is one sign which is known as cortical rim sign, commonly seen in renal infarction. So what happens is the rim of the cortex enhances due to the collateral capsular perfusion. And the other finding which we can see is flip-flop enhancement, in which the region of hypoenhancement on early phase becomes hyperattenuating on delayed phase. So the differential diagnosis for renal infarction cases is pyelonephritis. But in pyelonephritis, there will be absence of cortical rim sign. Also, the clinical presentation will be different in cases of pyelonephritis. Patient will usually present with fever, UTI, and there will be lot of pain in such cases. Thank you for watching.